Hello my dear curious and studious students of surgery. Myself Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Welcome students in our surgery lecture number 13, cholecystitis and Chole-docho-lithiasis. In this lecture we will learn acute acallulus cholecystitis, Chole-docho-lithiasis, bile duct stricture and carcinoma of the gallbladder. We start with the acute acallulus cholecystitis. Acute acallulus cholecystitis, that is the absence of gallstones in approximately 8% of cases. There is the absence of gallstones even though there is a acute cholecystitis. That condition called as a acute acallulus cholecystitis. This condition is more common in male, ratio of 1.5:1. Etiology, three major factors: stasis, sepsis and ischemia. First etiology factor is stasis, may be absence of release of cholecystokinin, cause regular contraction of gallbladder. Sludge, sludge is the main cause. With extraction of water from the gallbladder, bile is reduced to a viscid material known as a sludge. Such as viscid bile may cause functional obstruction of the gallbladder, leading to edema, venous and lymphatic obstruction, necrosis, etc. Stasis will also render it more susceptible to colonization of bacteria. Sludge is the cause for the susceptible colonization of bacteria in the CBD. Stasis caused by the lack of oral nutrient intake, trauma during the operation or any other reasons, blunt trauma of the abdomen, post major operative procedures. Here is the image of the ultrasonography. You can see the tender gallbladder on your screen. On the image you can observe the wall of the gallbladder is tender and there is a acallulus cholecystitis, means there is no image of the gallbladder stone. Here is the other image of the acallulus cholecystitis. There is no presence of the stones. Second etiological factor is sepsis. Injection of E. coli endotoxin causes acute cholecystitis. Third etiological factor is ischemia. Decreased blood flow to the gallbladder and epithelium may cause ulcers in the mucous membrane. Concentrated bile acid gets access to the gallbladder and being toxic to the tissues. Chemical burn of the wall of the ischemia. Pathology, almost similar to that of the calculus cholecystitis. Only difference is that a calculus cholecystitis variety is more prone to gangrene and perforation, and treatment is a calculus cholecystitis emergency cholecystectomy. Now the second point of this lecture is Chole-docho-lithiasis, means the stone in the CBD. 10% of cases of Chole-lithiasis stone found in the CBD. Majority of the cases stones migrate from gallbladder and known as the secondary in the bile duct stones. Clinical features: CBD stones may rarely be asymptomatic, rise to only vague indigestion, pain, typically biliary colic, pain in right hypochondral region, radiating to black to the inferior angle of the right scapula, jaundice. Within 48 hours, the pain is followed by the jaundice, urine becomes yellow with bile and the feces becomes pale, fever, chills with fever due to cholangitis. Here is the image you can see on your screen that there is a gallbladder stones and there is a stone in the CBD. Due to that there is a obstructions. This image more clearly shown. There is a Chole-docho-lithiasis, hepatolithiasis and Chole-lithiasis. All types of stones are showing in this image. This is more clear picture which showing the stone in the CBD. Now the Courvoisier's law. What is the Courvoisier's law? If in a jaundice patient the gallbladder is enlarged and palpable, it is palpable not a cases of stone in CBD, because in that case previous cholecystitis has already made the gallbladder fibrotic and small, when gallbladder is probably enlarged in case of jaundice. It is probably due to neoplastic obstruction in the distal part of the bile duct, either carcinoma of the ampulla of Vater or carcinoma of the head of pancreas. Special investigations: WBC count is usually elevated, ultrasonography and ERCP for diagnostic as well as the therapeutic. Advantages that sphincterotomy or papillotomy can be performed by the ERCP. Complications: suppurative cholangitis, impairment of liver function, hydrohepatosis, gross dilatation of intrahepatic biliary canaliculi which are filled up with white bile, Stone may ulcerate, acute pancreatitis. All these are the complications of the ERCP. Now the treatment of Chole-docho-lithiasis, preoperative preparations like antibiotics, it should be broad spectrum, analgesics, relaxant of sphincter of Oddi, anticholinergic drugs is to be used for this to relax the sphincter of Oddi. Vitamin K should be given parenterally for 7 days, that is a 10 mg daily, IV or IM. Required to raise the prothrombin level in the blood. Due to deficiency of bile salts in the distal ileum, vitamin K is not absorbed properly and this leads to prothrombin deficiency. That's why injection of vitamin K should be administered. Prefer vitamin K. Glucose drink to combat liver failure. High carbohydrate, low protein and no fat rich in calorie. Blood transfusion. Mannitol to promote diuresis to prevent renal failure, which is often seen in jaundice patient. Surgery, choledochostomy. There are 3 types: supraduodenal choledochostomy, retroduodenal choledochostomy, transduodenal choledochostomy. Third type is when the stone is impacted just above the ampulla of Vater. Now the next point is bile duct stricture, narrowing of the lumen. Classified in 2 groups. One is benign and B type is malignant stricture. First we will see the benign stricture. There is a multiple causes like traumatic stricture, inflammatory stricture, fibrosis of sphincter of Oddi. First, traumatic stricture, mainly iatrogenic, following by cholecystectomy or bile duct surgery. Second is inflammatory stricture due to accumulation of bile around the CBD. Stenosing cholangitis, sclerosing cholangitis. There is a fibrosis, submucosal and serosal layers of the wall of the duct. Ascitic cholangiopathitis, cholangitis of various etiology. Next point is the fibrosis of sphincter of Oddi. The female and male ratio is 3:1. The treatment of the bile duct stricture is transduodenal sphincterotomy. Here is you can see the bile duct stricture of narrowing the lumen of the CBD, stenosis of the common bile duct, diameter is less than 1.5 mm. Also there is a picture of the narrowing the lumen of the cystic duct, common hepatic duct, and on the cholangiography you can see there is a stricture that biliary tree is not completing their tree. Another image of cholangiography. Now the next point is the carcinoma of the gallbladder. CA of the gallbladder is the most common malignant lesion in the biliary tree. Female and male ratio is 4:1. Associated condition often associated with gallstones, cholecystoenteric fistula, porcelain gallbladder, ulcerative colitis. Pathology of the carcinoma of the gallbladder is 90% of the carcinoma of the gallbladder is adenocarcinoma, 7% is undifferentiated carcinoma, 3% is squamous cell carcinoma, and only 1% mixed carcinoma or adenocanthoma. Here is a image. You can see the carcinoma of the gallbladder, wall of the gallbladder. This is the image of the carcinoma of the gallbladder. Another image of the carcinoma of the gallbladder as well as the cystic duct. Now the spread of the carcinoma of the gallbladder is by the 5 way. First is the direct infiltration, second is lymphatic spread, third is vascular spread, third is intraductal spread, and fifth is intraperitoneal seedling. Treatment: radical resections, palliative procedure to relieve the obstructive jaundice, palliative T-tube intubation. Guys, here is the end of our surgery lecture number 13, that is the cholecystitis and Chole-docho-lithiasis. Thank you.